Thank you very much. Thank you for that kind introduction. It's a pleasure to be here and to share my research with you today. This afternoon we are going to talk about medical interpreting and cross-cultural communication, and we are specifically going to discuss the role of the interpreter. The interpreter has been portrayed differently through history, and so I'm going to divide my presentation in three parts. First, I'm going to tell you about how interpreters perceive their role in the first part of the research, then how interpreters enact their role. And for that, we'll have a performance, a live performance. I'll introduce the actors and actresses in due time. And then we are going to hear the interpreters' voices as they talk about their role. But so first, let's look a little bit at how they have been portrayed in history. In the late 70s, interpreters were conceptualized as a conduit. So information went through them, therefore underlying this model, there's the assumption that there is only one meaning, and meaning can get transferred linearly. Research coming out from sociolinguistics is helping us see that this is really not the case, and interpreters are in fact interacting during the interpreted communicative event. Since interpreters are seldom given a turn at talk, it's not unusual to hear somebody say, "Don't tell the doctor I'm not going to do this," and they are addressing the interpreter directly. Or it's not unusual to hear the provider saying, "Ask her about this and that." So interpreters have been addressed at talk. And what was of interest to me was to understand what triggered this participation of interpreters. So when you look at the interpreted communicative event, we see an event like the one we are having now, that's a communicative event, that's constrained by an institution, which is also part of a larger society. Therefore, these social factors such as age, gender, socioeconomic status are permeating every layer of this interaction, and the interpreter is not an exception. It's no exception to that. Therefore, many social factors may be affecting the way in which the interpreter is perceiving what's going on, and therefore how he or she deals with that reality. I'm suggesting three sets of interdisciplinary lenses to look at this problem, to try and understand what the role of the interpreter looks like. And I'm understanding that even when we have three great lenses, they may or may not be enough. The first one I'm going to suggest is the lens of social theory that helps us look at the interpreted communicative event at the level of the institution and society. So looking at the cultural norms or societal blueprints and how they permeate the event that we are seeing. The lens of sociological theories help us look at the interpreted communicative event at the level of interpersonal relation. So for example, we can ask the question, absolutely. I'm sorry. So sorry. And I had it in my mind that not only I was going to introduce the interpreter and thank the interpreter for doing her job, and also I was going to say, if you want to see a live performance, you look at her now, and then you look at the one that I'll perform, and it'll be quite different. I'm so sorry. So if now we move into the lens of sociological theories, what I was going to say is that when people come together, they come together for two reasons, and two reasons only. They help us see that. We come together because we seek information. You think I have something to tell you, and I think you have something to tell me, and we learn from each other. And we come together because of affect. So in the case of the medical appointment that we will see, the two come together alive because the patient has information the provider needs to make a decision. The provider has information the patient needs, and the interpreter has the information of the language and the culture that they need so that they can understand each other. And the third lens that I'm going to propose we use is the lens of linguistic anthropology. With this lens, we can look at the interpreted communicative event at the level of discourse. And we can look at what words are saying, why words are there, and how they are interpreted because of the context in which they are happening and who's interpreting them. So to give you a quick example, the work of Gil and Cepeda on a Wolof village, there was a couple that was celebrating their anniversary. And so to celebrate their anniversary, they hired a singer. But they didn't pay the singer quite well. So the singer didn't feel good about it and wanted to protest in some way or other, and decided to overpraise this couple during the singing. And so the overpraising was something like, "You, the king and the queen of the village, blah, blah, blah." So that overpraising only became an insult for this couple because the neighbors were there and knew that they were not the real king and queen of the village. Had the neighbors not been there and they had been overpraised, we don't know if that would have become an insult or not. But it goes to a point of what a witness, what a third person in a conversation may or may not cause. So how words are perceived differently and interpreted differently according to where they are uttered and who's present during that utterance. So these three lenses, I hope, are going to help us look at the interpersonal role of the interpreter in a different way. And so in order to do that, I'm going to share with you or suggest a study that I've done at two different levels. I call it a funneling approach to the study of the interpersonal role of the interpreter because it starts large across settings, across three different settings in three countries, and then zooms in to one specific setting in one place. And I'm going to be highlighting for you the top or the bottom part of the funnel to signal where we are. So two different questions guides this study that are trying to get at the role of the interpreter. On the top part, we understand that interpreters are neither invisible nor visible. They are not in complete control of the conversation. They are part of the conversation. So we ask the question on the continuum of visibility or invisibility for interpreters' perceptions of their role. Where do interpreters fall? At this part of the research, I can only get to interpreters' beliefs or perceptions about their role because I'm only doing that through a survey. And at the bottom part of the funnel, we look at the interpreters as they act out their role, as they perform interpreting, and we ask the question, what is the role that interpreters play during a communicative event? So first, top part of the funnel in yellow, we are in that study where in order to measure how interpreters perceive their role, I first had to design an instrument because there was no instrument to measure it. So the interpreter's interpersonal role inventory, or IPRI, was designed with an alpha of 0.9, so we can be quite certain that this instrument is measuring the interpreter's perception about their roles and their beliefs about their practice. And the instrument has two parts to it. The first part asks background questions so that I can get at social factors and then correlate the social factors with the interpreter's perceptions of their role. And part B has the variable visibility that is defined as interpreters aligning with one of the parties, for example, interpreters is establishing rules for communication, like we see on number 5, interpreters establishing trust, facilitating mutual respect during the interaction in things that they do, communicating affect as well as the content of the message, sometimes holding a hand, doing things that Code of Ethics would tell us we cannot do, but interpreters in some cases are doing. They are communicating affect through caring and asking questions, and explaining cultural gaps and interpreting culture as well as language. So we will see interpreters brokering certain concepts that belong to one of the cultures. So I sent out 967 of these. This came out of doing a stratified sample to try and keep the picture as it was, and 293 came back representing the 3 countries that I had sampled, Canada, Mexico, and the United States. And I sampled interpreters working in 3 different areas, interpreters that worked in conferences, that worked in the courts, in legal interpreting, and those who worked in the healthcare sector. So that's the population that make up the instrument. Out of these participants, 70% were female, 26 were male, and I don't want to read all of this. This gives you an idea of who the population was that was sampled and what their level of education, income, and average of age. And so my question was, do social factors correlate with this variable visibility, yes or no? And there was no significant correlation for gender. There was a significant correlation for self-identification for those who said, I identify more with the minority group. Of course, I couldn't ask the question of race because I cannot ask it on a survey, but I got at race with this notion of minority groups or majority groups. A correlation with income, formal education, and a slight negative correlation with age, meaning the interpreters that are older think of themselves as less visible, like they don't do any of these things of aligning and whatnot. And in terms of findings, the scale, IPRI called for a scale from 1 to 6, the part of the questionnaire that the interpreters had to complete. And the only thing I want to highlight are these ranges over here. Well, it doesn't matter. Which is like, if you look at these columns here, the range is 1 through 6, you will see that even those that came out as less visible were over the middle point at the maximum range. What this is really telling us with almost 99% certainty that it's not due to chance is that interpreters perceive their role as visible wherever they work, across the settings they work. And so, since the one that came out as the most visible group, the group that acknowledged their visibility or their agency more, was the one on interpreters working in healthcare sectors, I wanted to understand what that meant. And so now we go to the bottom part of the funnel, and I'm going to discuss an ethnographic study that I conducted during 22 months when I followed in a hospital that I'm calling California Hope, 10 interpreters, English, Spanish, and 1 language service manager. So for 22 months, I walked with them from appointment to appointment. I was present during the appointments. I was sitting by them when they were taking calls on the phone and they were interpreting on the phone. I was attending meetings. I was seeing how they navigated different communicative situations and the institution. So I was using multiple data sources and multiple analysis that I will share with you now. I entered the site to learn what a medical interpreter does, what a medical interpreter thinks about the role, what the issues are, what the challenges are. And I was looking at the role, what they do when they enact their role, how does it unfold, and how it's enacted by them. And then within the practice of ethnographic study, I would have my hunches validated by them, and every time I was transcribing and going back with the same interpreter, I would show them data and ask, why did you do that? And trying to gain their perspective rather than mine. So this shows the different types of data that were used during the study, and the interpersonal role is where I'm staying focused and trying to learn more about. So from interviews and transcripts and jokes that they were telling to each other when they were waking from their booths. It was interesting because they can only speak into the microphone what the patient is hearing on the other side and the doctor is, so they would send messages to each other on paper balls so that it would not make any noise and interfere with the microphone. And so sometimes it was interesting to see when one of those landed on a coffee cup, what would happen to that interpretation. This hospital is placed in the county, which again is a pseudonym of Conte, which is in the Bay Area in California, a population of 800,000, a huge language diversity in there, and the group that was of interest to me is the Hispanic, that constituted 26.6% of the population. So this is not for you to read, but to see it's 10 interpreters, ages varying from 33 to 60 years old. They had worked in this hospital, some for 15 years and some only one for 6 months. And their level of education ranged from completing high school to being physicians in their country of origin. 3 of them out of the 10 were physicians in their country of origin. And I also asked them about their ethnic background and how they call themselves, even those that were, let's say, Chilean, but would talk of themselves as a Chilean American, for example. And so during my time at California Hope, I collected what ended up being 392 healthcare provider, patient interactions brokered by interpreters. So these 392 interactions were fully transcribed, and the slide you're seeing now on the screen attempts to represent a summary of those 392 interactions, and attempts to show what happens when the interpreter becomes more and more visible during the interaction, but most importantly, what strategies is the interpreter using to become more visible. So the column on the left is showing the visibility of the interpreter is becoming visible by authoring text. So the words were not given to the interpreter, and the interpreter is becoming the author of the text. So let's imagine the doctor says, take only transparent liquids. And so the interpreter doesn't say transparent liquids in the other language. They say, you cannot take orange juice. You need to take blah, blah, blah. And so the interpreter is becoming the author of text that he's producing. That authoring of text can have a high impact on the interaction or low impact. And so the column on the right-hand side is showing you the different behaviors that interpreters are using to become more and more visible. So we go from below, the openings and closings, things that can be completely inconsequential in an interaction. For example, I see two of you talking to each other, and I approach you, and I know one of you, but you don't introduce me to the other person. So after a while, I may say, hello, I'm Claudia. That introduction of the self may carry no consequences in the interaction. That's why I'm putting it at the bottom of the screen. It says, high inconsequential, perhaps. And then we move up. When interpreters are saying, good morning, Mr. Maria, Mrs. Maria, I'm going to help you communicate with the doctor. Or I'm here to interpret. I'm an interpreter from this hospital. We are going to speak to the doctor. So the use of a personal pronoun, creating a team, or talking about the self. Controlling the flow of traffic when the interpreter is forced to say, okay, now you need to stop now and I will talk, because if you talk over me, then we will not understand each other. If the physicians are using technical terms, such as chronic illnesses, some interpreters feel the need to broker that. And so that's the sliding up and down the register scale and refer to any illnesses running in the family like liver or heart, and they start brokering that up. And all the way to almost replacing one of the monolingual interlocutors. So the interpreter becoming the speaker. And we will see examples of this in the second part of the presentation, and I'm going to introduce now the actress and the actor that are going to join us. Thank you, Alex and Kevin, for doing this. And we'll move now to perform this for you. And what I will do is I will introduce each of the segments. You will see a segment by segment slide that tells you what we are discussing. The first one is the opening of a conversation. So the bullet points are telling you we'll be watching for the positioning of the self, the use of pronouns. And this is an appointment that begins when Maria, the patient, sitting on my left, is coming in for an appointment. And we have here Kevin performing all of the roles of the patients, and Alex performing the medical assistant, the doctor, and the nurse. Okay? And now we have no, okay. Okay, there we go. So I'm an interpreter, and I have been introduced to the doctor, but not to the patient. So I'm coming in, we are all coming in together at this point where I'm saying, thank you, doctor. Let me introduce myself to the patient. Miss Maria Cabrera, good morning.
Good morning.
I'm an interpreter in this hospital, and I'm going to help you so that you can communicate with Dr. Pang.
Yes.
We are ready, doctor. So in the second segment, we are going to see an increase in this visibility. And we have Jimena and the medical assistant to Dr. Jacob. And the interaction is about changing an appointment.
She should be keeping that appointment for the 26th. And then, you know, if she has any questions or problems before then, she can give us a call.
Okay.
Okay, but as far as, you know, moving her up sooner, he has no opening before then?
Well, you have to keep your appointment. You should not miss your appointment on the 26th.
Fine.
Okay, but if between now and the 26th there's any problem, anything, then you call us. You call us to let us know, okay?
Of course.
And we'll let Dr. Jacob know, so don't miss your appointment on the 26th, okay?
Oh, all right. Thank you.
Okay, Jimena. It's very kind of you. Bye now.
Okay, but as far as, moving her up sooner, he has no opening before then.
Thank you, and I wish you well.
Fine.
So we saw closing the interaction with Jimena while the medical assistant was still trying to understand if we were going to move the interaction or not. And we go now into segment 3. We are coming now when the doctor is trying to explore if the medicine is helping the patient or not.
So it helps you or it doesn't?
Does it help you or not?
No, well, it's not. It's painful, and
But does it help you?
earlier I was feeling a little better, but this morning,
It does help her then?
She's not answering my question, doctor. Why don't you tell me if the medicine is helping you or not?
well, how can I explain it if I don't walk?
Ma'am, hold on here. We are going to do the following. When I talk, you stay quiet, and when you talk, I listen. Otherwise, it's impossible and we don't understand each other. We are now going to look at exploring answers. This is a pre-surgical appointment, and the patient is a child, so we have the father speaking for the child.
His surgery time is for 8:30 January 20th. He needs to be here on time. If he's going to be late, he needs to call us. Our phone number is 555-1234, and let us know he's going to be late or it's going to cancel.
Are you going to give him a copy of the number?
Yes, the number is right here. It's
Okay.
in the...
Okay, listen. In case you can't come to on the 20th at 8:30 for any reason, please call this number,
Okay,
the number that she's indicating.
okay,
Okay, and just let him be aware that we are a trauma center, and although his son's surgery time or registration time is for 8:30 that morning, that doesn't necessarily mean his son is going to have surgery at that time.
Okay. Sometimes emergencies happen. So it's not always certain that surgery would take place at that time.
okay.
For now, it's programmed for that time.
8:30. But should a problem arise, they will schedule it later.
That's right.
Okay.
Okay, does he have any other questions?
Any other questions?
No, nothing else?
Okay, can you please sign and date this pre-op instruction form, and I'll give him a copy of these instructions.
Sign there, please, and she's going to give you the copy. Don't give him any candy or chewing gum. Absolutely nothing, okay?
Okay.
Any loose teeth?
No.
No more questions?
Any other questions?
No.
Okay. In the next segment, we are going to see a doctor inquiring about medical history, actually a nurse, and we'll see examples of exploring answers, expanding and summarizing, and brokering cultural references.
Can you ask her about chronic illnesses, diabetes, all that?
Okay, Ms. Mesa, has a doctor ever told you, even 20 years ago, here or there, that you had diabetes?
No.
That you had high blood pressure?
No.
That you had heart disease?
No.
That you suffered from liver problems, kidney problems, stomach problems?
No.
Have you ever been operated on or hospitalized here or there?
No.
You have never been sick?
Well, I was sick, but it was nervous depression. I didn't suffer from anything else.
Okay, and were you hospitalized for nervous depression?
Yes.
Over there or here?
In Azusa.
Where?
In Azusa, near Los Angeles.
Yeah. She is saying that she denies diabetes, denies cardiovascular disease, denies blood pressure, denies problems with her stomach and her liver. She said that she denies surgery. She was admitted once close to Los Angeles for depression.
Okay, but she does not take any medicine now?
Ma'am, are you taking any medicine these days?
No.
Any over-the-counter medicine?
No.
That you brought from there, that La Comadre Juana gave you?
No, nothing.
Negative, negative.
Okay, all right. Sounds just like she has the blues. Her lungs are clear, she's breathing fine, her color looks good. I'm gonna check her oxygen saturation and then probably send her home with advice and give her the number to call.
Okay, our nurse says
I'll be right back.
that she has heard your lungs and they are fine,
Yes.
that your skin color looks fine, and that she will measure the oxygen in your blood.
Okay.
That doesn't hurt, and she will put a little light on one of your fingers during 1 minute, and then she will send you home with advice.
Okay.
So the next segment, we are going to see the use of the pain rating scale, and the interaction is between Señora Rita, the interpreter, and Dr. Brown.
In a scale from 1 to 10, how would she rate her pain?
Let's see, Miss Rita, in a scale from 1 to 10, what number would you assign to your pain? For example, if 1 is a pain that would allow you to go dancing, you almost don't feel anything, and 10 is so painful that you're dying from that pain.
What did you say?
What number would you give to your pain?
Well, it hurts a lot.
How much is a lot, ma'am? Does a lot mean you're dying from the pain?
Well, no, not dying, but,
Which things can you do when you're in pain?
well, I don't know. When it's very hard, I sit down.
But can you cook when you're in pain?
Sometimes it's very hard and I can't.
And at that times, does it feel like you're going to die? Or is it not so hard?
No, not like I'm going to die. It's just hitting me hard.
Do we give it an 8 or a 9?
I don't know. Yes.
When it's most painful, it would be close to an 8, doctor.
Okay.
Okay, in the next segment, we will see examples of controlling the traffic of communication, exercising power, expanding, summarizing, almost replacing a monolingual interlocutor at the very end. It'll be total replacement.
So, you don't give me an appointment to go there?
Ma'am, call the paramedics at 911, okay, ma'am?
All right.
Mauro, ask her who else is in the house.
Who else is in your house, ma'am?
A woman that lives here, because I rent a room here from that woman.
She's renting one of the rooms in the house. Do you want to speak to the other woman?
Yeah, let's try to talk to someone else.
Let me speak with the person that lives with you.
Let's see. Excuse me.
So while the patient puts the other woman on the line, she's off the line, and Mauro and the nurse are talking about denial that this patient is having, how typical this is, how classic this denial is, and they also discuss how busy last night was at the hospital. If the service, the staff service had to call outside help, has to call a phone line to ask for more interpreters. This is all happening when the woman is looking for the landlady. Here she comes.
Hello?
Does this lady speak English?
Do you speak English?
No.
Look, miss.
Mrs.?
Sorry, ma'am. You are speaking with Mary, one of the county nurses. My name is Mauro Sanchez. I'm one of the county interpreters. The situation is with Mrs. Fernandez is that we think she may have a heart attack.
No. I mean, she's able to walk fine. She only wanted to check.
No, listen.
Oh.
Listen, we want you to call 911 so that the paramedics can come check her. They can determine if she's indeed having a heart attack or not, okay? But before doing anything else, call 911 so that they can come to check her.
Oh, okay.
If she doesn't have a heart attack, that's great, right? But the symptoms that she's describing are very compatible with a heart attack.
Yes.
Okay? Okay, so I told her the situation. We are trying to encourage her to have her call 911.
All right, okay. Thanks, Maro. Okay, bye-bye.
Bye. Thank you very much. Thank you for your patience with me trying to work the screen, the phone, and everything. So after looking at how the interpreter unfolded in practice, I went back to each of these 10 interpreters and I asked them questions. I interviewed them, I went back with their transcripts, I checked for their interpretation of the transcripts, and during my interviews, I wanted to explore how interpreters felt vis-a-vis the parties that they were talking to, like what they thought about healthcare providers and about interpreters. I also wanted to find out what sources of stress they were facing in their workplace and what were the tensions. And most importantly, their own opinions and definitions of their role, which of course I didn't ask in this way. When I asked the questions, you can see on the screen these recurring themes. The perceptions of the parties for whom they work, they were thinking that in general, the problem was that patients were not understanding what they were told. So for them, the low degree of education was one of the problems. They perceived providers as the ones who had the authority and who couldn't sometimes understand the social reality of the patients. Out of the 10 interpreters, I should point out, only one expressed that, stated clearly that the problem was that the providers were not understanding the social reality from where interpreters were coming from, that they were talking down at them and they were not aware when they were not able to understand information. When I ask about stress and tensions at work, they of course mentioned the notion of accuracy, being accurate and at the same time being able to broker communication. So staying on message and being accurate, but allowing the other party to understand and brokering that for them. They found very stressful to talk about death across cultures. They mentioned over and over again when in terminal cases, when the family was approached for organ donation, they always had to broker and stop the providers in not doing that in a very direct way. The way it was done in California was when they knew that a patient, there was a very high chance that the patient was going to pass away, to approach the family and get things lined up for organ donation. And so the interpreters were always finding that inappropriate for other cultures and were discussing that with me. And of course, measuring pain, and most importantly, the use of the pain scale. All of them had problems. I was fortunate enough to have the 10 of them going through pain scale several times during my observations, and they all talked about the impossibility of using that pain scale. They understood why it's used, but it wasn't easy anyway. So they felt that it was their job to broker that, to illustrate with examples of what could or could not be done in pain. So during the interviews also, I saw many metaphors emerging. So interpreters were talking about themselves as bridges, as different types of bridges. They were also referring to themselves as mind diggers because they had to dig out information. When the patient was not providing that to them, they were constantly making an effort to get it out. They were pursuing different routes to get the information that they needed. And the one that stayed with me, and my favorite, is they refer to their job as one of a diamond connoisseur. And so I asked this interpreter, what do you mean by that? And he goes, well, you know, I really need to see and be able to separate the stone from the dirt and keep that dirt handy because I never know when I'm going to need it. The dirt being the stories that patients tell when they are asked, does it hurt or doesn't you? They hardly ever go yes or no, but they tell a story when it hurts or when it doesn't. And interpreters never know when that story is going to become handy to answer a question at hand, so they have to remember that. So looking at the role of the interpreter from the level of what interpreters perceive or believe about their practice to how interpreters act out their role and how they talk about it, the study concludes with relevant propositions to interpreters' visibility, as the interpreters in all the settings perceive their role to some degree as visible. They also enact visibility by claiming text ownership, by becoming authors of text. They enact that agency that they have. And they talk about visibility in their own words when they refer to the job that they do. So I think this work has, I hope, helped us look at interpreters in a different light from the one that we get if we read only code of ethics and rules that prescribe the role of the interpreter to be quite transparent and accurate. When that role falls out in practice, it takes many shapes and many colors. And through the transcripts that you've witnessed, you saw interpreters who were taking on this role of, can you ask her about chronic illnesses and all that? And the interpreter went and did it. And of course, I asked the question, why do you understand the responsibility that you're incurring? Why are you doing this? And they all referred to themselves as team players, that they are expected to do that because they have worked so many years in this hospital and they have been trained, and the staff members expect them to be part of this team. So all of these things go perhaps against everything we teach and we read, but we are seeing more and more of the education and certification of interpreters to start to take these issues into account rather than assuming them. So if we believe that interpreters need to be invisible, we need to test for that. We need to make sure that we meet the students or the interpreters, practitioners who are taking part in our courses, that we meet them where they are. And so we talk about the problems, the responsibilities of exercising that agency, of taking the role of a provider instead of the interpreter, and not assume that they are not going to do it. Especially these days when we get many of our classrooms populated by heritage speakers who have been interpreting for their families since they were 10 or 12 years old. And for them, interpreting has always been about helping my family communicate. So we need to make sure that we understand where the students are coming from in order to meet them there and explain to them what professional interpreting is about and how it differs. I think this work has also implications for professional organizations, for reconceptualizing code of ethics and making sure code of ethics are not only theoretical propositions, but are based on empirical work. It has implications for the education of healthcare providers. Healthcare providers need to learn how to speak through interpreters, and they cannot just turn around and say, you know, as I witnessed on a treadmill, a provider telling the interpreter, you know, you're more familiar with gestures in this culture than I am, so why don't you watch the patient if he's becoming uncomfortable, getting short of breath and whatnot. Those are responsibilities that the interpreters are not trained to be able to do. It has implications for cross-cultural communication as a whole, cross-linguistic communication, and most importantly, I think it has implications for issues of equal access to services, because when we think that we need to provide equal access to services such as health, education, or justice, we don't if we don't have interpreting that allows the parties to communicate. So with this, I'm going to close. Thank you for your attention and open the floor for questions, if that's okay.